My name is Jan Ehrchen. I'm working at the Department of Dermatology at the University Hospital of Münster. The second patient I want to discuss is a female patient, 50 years old. She had quite typical skin involvement. So we see this livid erythema on the back of her small finger joint at the hands. We see the erythema at her cleavage in this V shape, and we also see the erythema on the back of her neck. So typical textbook signs of dermatomyositis in this patient. We did not find clear evidence of muscle involvement in this patient. She was complaining of myofascial pain, but there was no really strong indication. We also have to look for the autoantibody profile, which of course we did, and we found antibodies directed against TIF1-γ in our patient. And TIF1-γ is an important antibody to know because there's a strong association with malignancy in patients with this autoantibody. So we also had to do a thorough workup to exclude malignancy in our patient. Fortunately, we did not find any malignancy in our patient. Nevertheless, of course, she had a severe impairment of her quality of life due to these persistent skin lesions. Since we tried everything which a dermatologist can do to improve these skin lesions, we were treating her with local anti-inflammatory therapy, local glucocorticoids. We were giving her hydroxychloroquine, and we also gave her systemic steroids and azathioprine to improve her skin condition. Unfortunately, she was not responding to any of our therapeutic procedures. And so we were quite thrilled that in 2017, the first large trial of intravenous immunoglobulin in dermatomyositis was started, the ProDerm trial, which enrolled patients with active dermatomyositis which did not respond to conventional immunosuppressive therapy. Our patient and 94 patients in other sites and other countries were enrolled in the trial to receive either EVIC, 2 gram per kilogram body weight, or placebo every 4 weeks for 16 weeks. The primary endpoint of the trial was improvement in the total improvement score, which is a validated composite score for dermatomyositis of at least 20 after 16 weeks. The proportion of patients which achieved this goal of the trial was much greater for the patients which were treated with IVIC. So our patient was enrolled in this trial, and later on we recognized that she was randomized to the IVIG arm, and as can be seen here, there was quite good improvement of her skin conditions after treatment with the intravenous immunoglobulins. So the results of this trial, the highly significant difference between IVIG and placebo, led to the approval of the first IVIG for the treatment of active dermatomyositis in 2021. The patient experienced great benefit of her skin lesions and was very happy with this treatment. I think the important impact of the ProDerm trial on the treatment of dermatomyositis is that we now have the first formally approved IVIG for the treatment of active dermatomyositis. And of course, as a dermatologist, which I have to treat patients with severe skin involvement, and the skin usually does not respond very good to conventional therapies. So now we have something for the treatment of these patients, and I think that's an important impact of the ProDerm trial on the management of patients. Given that dermatomyositis is a very rare disease, the diagnosis is usually prolonged, especially in those patients who are suffering from skin symptoms, or at least at the beginning only from skin symptoms. Even for dermatologists, this is something which he encounters very rarely in his daily practice. So you always have to think of dermatomyositis. And in giving these two cases which I presented, we've seen the plethora of dermatological findings which we see in those patients. And so you always have to really think of the possibility of not missing patients with this rare disorder, and then to initiate diagnostic procedures with other faculties, with other specialties to really make the diagnosis. An important point, which is really highlighted by the second patients, even if we did not find a malignancy in our patient, is the increasing importance of autoantibody diagnostic in dermatomyositis. 10 years ago, we did not find autoantibodies in more than half of the patients. However, in the last years, new myocytic-specific antibodies have been described, and these antibodies have important prognostic values for the patient. So we've seen this antibody TIF1-gamma, which is really associated with malignancy. Up to 80% of the patients with TIF1-gamma are reported to suffer from malignancy. There are other autoantibodies, like for instance MDA5, which can be associated with very severe lung involvement, with lung fibrosis. Other antibodies, like the anti-synthetase antibodies like YO1 and others of this group, are also associated with severe lung involvement. Finally, there are some antibodies like NXP2, which can be involved with specific skin syndromes like calcinosis, which also required some special treatment options. In my opinion, in the next years, we will really stratify patients with dermatomyositis according to their autoantibody profile, and there will be investigations focused on these subtypes of dermatomyositis. We already know that they have a very high prognostic value for the patients. But of course, in the future, these autoantibodies and these different subtypes may also give us some indication as to which therapy we would choose as first-line therapy in perhaps different groups of patients regarding to the autoantibody profile. So I think the future research should be directed into these areas of stratifying these patients according to the autoantibody profile, and then perhaps initiating treatment according to these autoantibodies and see whether there are some patients that, for instance, will benefit from different treatments.